Welcome to the Victorian Chamber of Commerce and Industry. My name is Anton Zidnik and I manage the Health, Safety and Wellbeing team. In this conversation, I will be discussing occupational violence with my colleague Lauren Heatley. Lauren is a health, safety and wellbeing consultant with over 20 years experience in both physical and mental health care. In the early stage of her career, she worked as a psychiatric nurse in a variety of different clinical settings. In this conversation, I asked her to reflect on some of her experiences of occupational violence in the workplace and share some recommendations on what employers should be doing to effectively manage this complex area of risk. We discuss how employers can create a positive workplace culture that encourages reporting and provides effective post-incident response. We also discuss best practice design principles and what employers should be thinking about when training their staff. So Lauren, thank you for joining me. For the benefit of our listeners, could you please give me a little summary of your professional background and how it is that you come to be an expert on the topic of occupational violence?
Occupational violence obviously is quite a big issue in mental health, nursing or nursing, but particularly in mental health, it's an issue that can't be removed completely. So the hazard's still there, the risk is still quite large. It was the way that environment was controlled that enabled me to continue working in there for quite a period of time. Over
How many years did you work in that field?
It was 10 years.
10 years
over 10
in mental
years.
health nursing. Okay.
Yeah.
Okay. I was particularly struck when we first spoke. You mentioned over that 10 years you had a range of experiences in different workplaces, some of which you felt quite safe and supported in, and others where you didn't and left pretty quickly. I was hoping you could share for the listeners, in your opinion, what are some of the elements that made you feel safe in some workplaces, and conversely, how were they lacking in workplaces where you didn't feel safe?
Yeah, sure. So where I worked for the majority of my time, as I was saying, the occupational violence, you can't remove it completely, but to control it as much as you can to minimize the risk. So the main workplace I was at looked at a range of different supports in regards to minimizing that risk. So whether it looked at different controls that the workplace could put in place to ensure that the staff were as safe as possible, they were supported in their roles. I always felt that I was supported by staff members I could visually see, or I knew that there were staff members in the background that if an incident was to occur, that they would come to help support me.
Yeah, so the way that resourcing and rostering worked was done in a way that you had people close at hand.
Oh, yeah, definitely. And you want to reduce the risk of an incident happening at all. But if an incident did occur, that you would then have staff on board to be able to assist you immediately to support you.
When the occupational violence is initiated essentially by clients, what was the processes involved in your experience with attaching different levels of risk to different clients? Because obviously not everyone shared the same risk profile. How did the organisation go about that?
It would depend. It would look at a risk assessment based on the individual person in that situation. It was the behaviours that they were displaying, whether they would be seen or be classified as a high risk, medium or low risk. And then that would also depend on the amount of staff that were present at that time. Like I said, to help reduce the risk as much as possible.
There must surely have been circumstances where the risk level may have been ambiguous when you were taking on a new patient, for example, or it's not so much was known about their possible behaviours?
Yeah, and if there was a lot of unknown and it was in turn putting a risk to the staff, then it would be treated with higher measures, as in they would look at high risk and the additional controls until those unknowns were evident and, a correct risk could be put attached to the person.
So an assumption of high risk and until proven otherwise, effectively. Yeah, okay.
Yeah, until there was more information.
How was consultation generally handled with the staff group? Tell me a bit about that, like in meetings and discussions, how involved were you and your colleagues in determining the adequacy of some of those controls?
The controls were regularly reviewed and the individual's risk rating as such. It was looked at with consultant psychiatrists. It's the medical world, so it is quite hierarchical in that sense. However, the decision wasn't just made by the person that was sitting at the top. It was in discussion with nurses as well that would understand what was going on a daily basis and how that person was presenting.
Other than staffing, can you give some other examples of how controls were used to reduce the risk? For example, around, safe spaces, barriers, design of space, that sort of thing.
Yep, certainly. So probably the very first thing that was looked at when the facilities were being built new was the design and layout of the workplace, just to the point where patients would have an area where they could walk off to by themselves. They weren't feeling like they were backed into a corner, that they were able to move around. And then it would depend in terms of the communication that you were having with them, different treatment options that may be available as well, and engagement still with, friends, family, having them come in to visit.
So it was a facility where the organisation had the luxury of design of space in advance, as opposed to having to retrofit an existing space that may not have been so ideal.
Yep, and it was essential when that building was being built, they actually got the nurse in charge to be involved through the consultation process, because the idea from the construction company and builders was very different and not fit for purpose with what needed to occur in the sense to manage and reduce that risk of occupational violence.
And what did your induction and training look like on that topic? How was it done well?
So it was really open. It was an open, transparent process. You could clearly see the supports that were available. So you had newer and not experienced staff members coming in that would be in turn buddied up with more experienced staff members until they were feeling comfortable in that role. And then once you reach that comfort level and you were happy with it, you still weren't left alone, as in there was always staff members around you. It wasn't just you working out on the floor by yourself.
And conversely, in other workplaces you might have worked in where you didn't feel safe, I remember there's one in particular you said that you left pretty quickly. What was your experience there like, and why? What were some of the elements?
So that having a staff member around was a huge point of difference for me. I was working in a high-risk area, and where I'd previously worked, if you did work in a high-risk area, you had at least 2 staff members there all the time. They knew my experience because at that stage I had quite a bit of experience with me, but they left me out there by myself and said to me that it was fine. They had a glass office. They could see me if there was any issues, but I felt incredibly alone, vulnerable, isolated, working out there by myself. I did not feel that I had the supports around me.
What was the rationale behind that? Was it budgetary constraints or?
Yeah, there was a bit of money attached to it as well. I think the culture of the workplace too was very much of, she'll be right, and what are you worried about? And that nothing bad's happened before when we've done this, so we're just going to leave you out there by yourself. But as an individual, it felt awful, and I felt very much at risk.
Can you comment at all on the way that different organisations handled post-incident support?
I would say post-incident, of course you don't want an incident to occur, but unfortunately they do. Ensuring that you're supported to begin with, but then once the incident has occurred, that you have an opportunity to debrief, and that you are getting those professional supports as well, because it's a very it's quite a traumatic environment, and it can put you in a bit of shock in the sense you don't know what's going on, what to expect next. So you do need that support after to see how you're going.
Underreporting of occupational violence incidents is pretty widespread across the board, particularly in healthcare. What do good organisations do to encourage employees to report not just incidents but also near misses and hazards, no matter how minor they might seem?
When I first started out, probably more so at the start, there was very much a culture of this is the job, this is just a part of it. You just kind of accepted it. But I think it did move to more of an awareness and being able to report near misses, not just the incidents, but near misses as well. And it also helped, which for me this changed over the years, it helped to have a reporting system that was fairly user-friendly and easy to use, because if you had to sit down and fill out a report for the next 10 minutes when you'd already been working an 8 or 10-hour shift, is not what you wanted to do. So I think making it easier to fill out the report and also having someone to assist you filling it out, not just the nurse in charge or whoever the senior person was saying you have to fill out this report, actually sitting with you and going through it.
And how was information sharing across shifts? Because one of the big risks with client-initiated violence is, the new person comes on shift and they don't necessarily know to the level of detail they should what's transpired in the previous shift. How did that work in the good organisations you worked with?
Yeah, I think there's a risk of information being missed. However, I would say the good organisations that I worked with always had a handover meeting, so from the shift before to the shift that was currently occurring, so they could give a verbal update of what had been happening, because you don't always capture everything in the written notes, and some nurses may not always have the time to read those written notes. So actually giving a verbal handover as well as the documented reports.
Client-initiated violence was obviously the principal risk, but was it also to some extent dealing with family members and other contacts of the patient that you came across this as well?
Yeah, definitely. There was certainly a risk there, and really trying to manage it as best you could. So to use safety language, trying to eliminate it. Number one, I can remember a shift where I was working where there was a very upset family member who hadn't actually, we didn't allow to come onto the ward at that stage because it was just going to cause additional issues. So if it can be removed, but I mean, it can't always be removed, and having family members participate is highly beneficial. But really, trying to manage it and reduce those risks as best as we could, which a lot of it did come down to the layout that we were talking about earlier and the building design, having rooms where people could meet and have those conversations without them feeling that they were being trapped, so to speak, or stuck in a room. That was really important.
And I'd presume as well that the standard design principles around visual points of access, two exits, those sorts of things were incorporated into the design. Yeah,
certainly. So that, you could see a way out of there, that it was, visually you weren't going into, a dark corridor or something like that.
What did training look like in terms of things like de-escalation techniques, and how was that handled in induction? How often was it repeated?
So working in that area, we underwent de-escalation, or there it was called management of clinical aggression. We went through that training at Induction, and then it was refreshed every year, that specific training. We did have many refreshers in between there if different equipment was being used, but bare minimum was to redo that every year, and that would look at de-escalation, different techniques that could be used in that situation.